All right, welcome to a first official UDAC, the Uromigos Drug Advisory Committee. Despite the government shutdown, we're going to proceed with this. That was Sam's joke. If it was funny, I was going to claim it as my own. So here's what's going to happen. So first of all, a couple of disclaimers. We don't know anything about, for these drugs, if there's an ODAC, if there's not, when it is, who's on. We don't know anything about it. So this is just a pure exercise because we thought it would be fun to do. Right? So there's no inside information here, to state that. We're going to do 2 half-hour sessions. The first one on sasanlimab, the second one on durvalumab, and they'll each be structured the same. I'm taking the role of the FDA, and I'm going to have one slide just showing the data, but mostly giving a critique of the data. Then I'm going to turn it over to a presenter, in this case Tom, and then Jonathan for POTOMAC, and then they're going to go through the data and tell you why they think it's great. And then our panel, and you guys can just introduce yourselves as you speak. Our panel will go through and ask questions for the next 10 minutes or so to the presenter. Then at that 20-minute mark, we're going to take a vote. There's a panel on stage. There's also a panel at the tables here. We just couldn't fit everyone on stage. Everybody will vote basically yes or no. You'll see the question. And then we'll ask them to go around and say how they voted and why they voted that way. And that's basically how an ODAC works. This will be, instead of 4 hours, compressed to 30 minutes. So, all right, we ready to start? I lost Tom. OK. All right, the panel is actually wrong because we changed people. All right, first we're going to talk about CREST. So just as a reminder, this is and both trials are in BCG naive, high-risk, non-muscle invasive bladder cancer. You see how the different categories that it was defined, high-grade, TA, T1, or CIS, obviously complete resection of visible disease. BCG induction and maintenance would be the standard. The experimental arm was adding 2 years of sasanlimab. In both trials, actually, there's a third arm of drug plus just BCG induction. We're really not going to talk about that in the interest of time. Primary endpoint of CREST, investigator-assessed event-free survival. The rest of the text is just the event, how they defined EFS. Time from randomization to recurrence of high-grade disease, progression of disease, persistence of CIS as applicable, or death, whichever came first. High-level results, EFS of 0.68, about a 7% difference in the 3-year EFS. Hazard ratio for OS not significant, in fact, above 1. And you can see the toxicity of about a 5-fold increase in toxicity, including high-dose steroid use. So there are significant issues with these data. You can see more patients on the experimental arm discontinued due to an adverse event. So they were not able to receive the standard therapy, which is the standard of care and has been for decades. This benefit is really driven by the CIS population in this trial. It's about 25–26% of patients. In the non-CIS population, the hazard ratio for EFS crosses 1. The event difference, you could see the 28 event difference is largely recurrence of high-grade disease, and I think this is a critical point, right? This is early disease in an elderly comorbid population, many of whom are not going to die of bladder cancer, and we should be intervening if we're actually making their lives better or longer or having them function better, right? So I would argue that recurrence of high-grade disease is not meaningful generally in this population of patients. There was a sensitivity analysis. If you look in the manuscript, there's a sensitivity analysis by blinded independent central review. Remember, this is an open label trial, investigator assessed, EFS as the endpoint, all sorts of bias that can creep into that. When you look at the blinded independent review, it was a negative trial. It was not statistically significant. Importantly, and I alluded to this, there's no difference in really what matters, right? What we care about in this patient population, progression to muscle invasive disease or / need for cystectomy or worse. OS not significant, so we're not making these patients live longer. In fact, the hazard ratio is above 1. There's significant toxicity, as you know, giving a systemic drug, a systemic immune therapy to a localized problem. And significant steroid use. Again, about a 5-fold increase in toxicity. You can see about a 20% high-dose steroid use, again, in this elderly and comorbid population. So the voting question, we're not voting now, but I'm just telling you what the voting question is basically an up-down. So basically, does the benefit risk of sasanlimab plus BCG induction and maintenance in this setting support approval of this regimen in non-muscle invasive bladder cancer? I'd like to invite my colleague Tom Powles to the stage to take the role of sponsor, and he's going to give us his sponsor presentation. Here you go.
Cheers.
He's going to give the sponsor presentation.
Thank you. This is my first foray into industry. It could easily be my last. Look, Bladder cancer is the 9th or 8th most common cancer. It's actually higher than that in the US. In Europe, it's 6th. 75% of these patients have non-muscle invasive bladder cancer. It's a very common disease, and local disease, T1, CIS, G3 disease, is very common and a huge healthcare burden. If anything, I read it's the most expensive cancer to manage. I may or may not be right in that because the prevalence is high. Also, these patients, during their lives, once you've had this diagnosis, are on a bladder cancer pathway and in harm's way. And preventing local relapse is an important intervention. It is true, whether you like it or not, that the biology supports early intervention with immune therapy. The earlier you go, the more the tumors are primed to respond. So these tumors are most likely to respond early, and it's likely, very likely, that those patients who have lethal disease, if we're lucky enough to catch them early enough, those patients that progress from CIS or from G3 into muscle-invasive disease, in the end will reap benefit from early immune checkpoint inhibition. It's very, very likely that that's the case. Salimab is a subcutaneous, it's not an intravenous, but a subcutaneous PD-1 inhibitor. It doesn't currently have a label in a license anywhere in the world, but this was the pivotal trial to achieve that label, and indeed, I'm sure the pharmaceutical industry will have discussed with various sponsors around the design of this particular trial called CREST. CREST is a very, very robust study. It's a randomized phase 3 study. It's 1,000 patients. We're not going to focus on the middle arm, induction and maintenance BCG. Maintenance BCG is incredibly important. As you can see, the curves go apart and they stay apart. We've hit our primary goal. We've said we would do what we have done. The EFS endpoint is the one that is most widely agreed and the one which indeed the other sponsor you'll hear from today also pursued, different from the endpoint with the Alban trial that was negative, which I think is important to point out. It was a positive trial in broad subgroups of patients. There was a degree of enrichment in the CIS population. The PD-L1 seemed to do nothing. The PD-L1 biomarker, for me, is a bust and shouldn't be pursued any further. And so I think it's fair to say we achieved our goals in unselected patients in this high-risk group. And therefore, with that, we feel that this should be approved and doctors and patients can make their decisions about whether it's appropriate for them. It is 2 years of immune checkpoint inhibition. We accept that it is associated with life-changing toxicity in some patients. Actually, though, the treatment-related deaths were extremely minimal in this trial, number one, which I don't think is accounting for the hazard ratio which you pertain to saying it was above 1. I would push back on that quite strongly. I think there's noise in that, and if it was the other way around, people wouldn't say the hazard ratio is 0.88, it's benefiting. So I think we should park that issue. Also, the number of deaths at the moment is very small, number one. Number two is you can see here the adverse event profile is in line with expectations for these drugs. We know in the community how to give these drugs, and the fact it's 2 years of therapy, almost all of the adverse events tend to occur during the first 6 months. So I don't think that should be a determining factor. So overall, we've done a big randomized phase 3 study, as we were asked. The endpoint that we agreed, we've hit our goal. The adverse event profile is in line with expectation. There weren't any new safety signals, and therefore there's no reason not to approve this and allow doctors and patients to decide what's best for them.
Thank you. All right. All right, we're going to open it up for 10 minutes to questions from our panel. We can start anywhere you'd like. Maybe introduce yourself when you ask your first question. Sam Chang.
Sam Chang, Nashville, Tennessee. Very, very lucky to work with Brian Rennie, or work for Brian Rennie as much as possible. But Dr. Powell, thank you very much, number one. Secondly, following your lead of asking questions that there are no answers for, let's start off with, why were the investigators not blinded?
So to the trial. Because I think, look, I take your point. I think giving 2 years of placebo would have had its own problems. I think we'd have lost, I just deep down, I don't think 2 years.
Were there
I think
differences?
I think there are ups and downsides to placebo-controlled trials.
Were there differences in the events measured by cystoscopy versus biopsy?
So I think in the trial, the event rate from cystoscopy, and there was a mandate. This is one of the trials that did have a mandatory biopsy in it. Were there different?
At 6 months,
Yes.
CR, CIS.
Yes.
But for the events,
Yes.
were there mandatory in terms of, I see disease cystoscopically, oh, that's an event, and was biopsy then required? And if that's the case, were there differences between just a cystoscopic evaluation versus a biopsy between the two arms? I ask because the investigators were not blinded.
So Sam, I
To
don't
whether or not
think
the guy-
anyone knows the answer to that question.
So along those lines, because I want to continue to ask questions that you don't know the answers for. So along those lines, what about, you probably know the answer to this. From sitting earlier in this, before the UDAC, cystectomy-free rate seems to be very important. So ultimately, was there a difference in cystectomy-free rate between the two arms in cohort A versus C?
So that's not currently public. I don't know the answer. One could find out the answer, I'm sure. One of the things I can tell you is that from a muscle-invasive rate,
Yes.
and that's not cystectomy, but the rate of muscle-invasive disease and the rate of advanced disease, in the trial, they were relatively modest.
And were there differences between the two arms?
When you look at the CIS population, in the subset of the CIS population, there were some subtle differences. When you look at the overall, it's underpowered to say there were differences in the two arms.
Okay.
But the bottom line on this is that the main difference, as Brian suggested, was local recurrence, not an advanced recurrence, and therefore the numbers become quite modest.
Great, thanks very much.
Thank you very much. During a real ODAC, you could say, we'll get back to you after the break. That's usually what you do. Brad.
Yeah, Brad McGregor.
Well, we do know the answer to those questions, and the numbers are quite more, they're not, and I think if we looked at cystectomy rates between the two, and I genuinely don't know the answer, I suspect you would, I don't think it's huge numbers. And I think your questions are fair,
So, Brad McGregor, I just had a quick question. So you have this beautiful treatment-related adverse event here with the tornado plot. What about those life-threatening, life-changing toxicities in this space where patients are not at imminent risk of death? So, such as diabetes, myocarditis. What are the risks of those life-altering toxicities?
So in this study, and there's no reason to suggest this would be different from other immune checkpoint inhibitor studies, we know the risks of life-changing toxicity, which you talk about. The commonest, and whether this is life-changing or not, would be hypothyroidism. That would be taking a tablet every day. That's about 20%. Yeah. Up and down a little bit in different studies. I think diabetes, cardiac toxicity, neurotoxicity, long-term respiratory toxicity, all about 1%. When you pull the life-changing serious together, I would say about 10%, and that's what I counsel my patients. When you say long-term consequential effect, if you include hypothyroidism, that goes up. I don't think hypothyroidism is life-changing toxicity personally. I think if you take a tablet when you have breakfast, that's okay. And I think that needs to be weighed up with the risk associated with local relapse. Coming back to Sam's question before, is this clearly having a massive effect on advanced disease and muscle-invasive disease and cystectomy rates? Perhaps not. Cystectomy as the endpoint of this trial would always be difficult. Lots of different reasons for having cystectomy. I wasn't super keen on that endpoint when these trials were designed. I believe it's the right endpoint. I believe it's robust, in my opinion, although I accept issues around blinding, there are practicalities associated with that. And in the end, doctors and their healthcare professionals will need to decide whether the risk and benefit of recurrence of potentially aggressive urothelial cancer and the 10% chance of life-changing toxicity is a fair balance.
So to that extent, I would say the number needed to harm is 10, and the number needed to benefit would be 13. So how do you weigh that benefit with the patient?
It comes back to what I said before, which is a discussion between the patients and the doctors. This clearly isn't extremely harmful. It's not that therapy. We know a lot about long-term immune checkpoint inhibition. We've talked about life-changing toxicity already. My feeling is there's a balance between bladder cancer and life-changing toxicity here. I think it's a fair debate, but I think patients and doctors rather than the FDA are better decided.
Okay, you've said that already.
Can I ask you a question? Are you seeking approval for all comers or only CIS positive patients?
Oh, we want an all-comer label. It's an all-comer trial. We want to go straight in.
I have a question about that. So in the trial, as we saw the data that...
Microphone, yeah.
I don't know if the mic is...
I think it's on. It was just to the side.
So we only saw that the patients with CIS derive benefit. Now, some people might argue that subgroup analyses should not be taken into consideration, but that was a stratification factor, and there's a reason we do stratification because we expect those patients to derive more benefit. And from the, large trials where subgroup analysis have helped us lead to nice trials like IMvigor010 or 011. So I think in this trial, can you provide one good reason why we should be offering it to patients who do not have CIS when the benefit was driven by CIS?
Yes, I can answer that question. So we did an intention to treat 1,000-patient study. It was a huge undertaking with all the caveats we've said before. I think the central pathology review is not the same as a central radiology review. I think we as oncologists are comfortable with that. Central pathology review is much more challenging. You don't get the sample necessarily always sent. You get slides rather than blocks. So I don't think that's why it wasn't the primary endpoint. And I don't think there's a bias associated with that. I don't think the doctors would be doing a different TURBT based on whether they've had sasallimab or not. So I don't think that blind issue was a problem in this particular study. I think blinding would have made it harder, not more difficult, number one. Number two, if you think, do we right now have a positive randomized trial with a primary endpoint with a hazard ratio of 0.68? That's a big, impressive hazard ratio. It's statistically significant. Yes, of course, we'll find a subset. I recognize the stratification factor, but the problem with CIS, and the urologists will confirm this with me, CIS is not one disease. CIS, you can have CIS in the whole of the bladder. You can have a papillary tumor with CIS around the edge. You can have mixed CIS and mixed tumor at the same time. You can have pure CIS. And so I'm not personally convinced that we know enough about CIS to be driving down yes, this is a CIS.
Ask another question. Without overall survival improvement, how would you justify using 2 years of immunotherapy in this early stage disease when we have advanced
As I said before,
therapy?
I don't think the second year of immune checkpoint inhibition is necessarily that harmful. I recognize there are other challenges logistically with it, firstly. But secondly, I don't think it will be totally unrealistic with a number of relapse events as it currently stands to expect overall survival. When we talk about immature data, from a survival perspective, this is clearly immature data. From a long-term, muscle-invasive bladder cancer is a 10-year story, not a short 2 or 3.
I'm just going to move on in the interest of time. I'm going to go Josh next, and then Matt, just to round out the questions.
I'm expecting a torpedo. I mean, Josh has asked the question. I think you're right. Are we sure it has activity?
So arm 2, for example, didn't really have much activity. And really, what we see from this is that BCG is doing 78%, 76% of the lift with a marginal 8% with the checkpoint. We've already approved a checkpoint that people don't use in this setting. So how do we know that doing that's going to actually lead to better outcomes?
So I'm going to take the question, two points individually. Is the drug active? Yes, it is. It's an immune checkpoint inhibitor. It's a positive randomized trial. It's clearly active. We've shown that in a really challenging setting, by the way. So it's definitely an active drug. There's no reason to suggest it's not active. It is an active immune checkpoint inhibitor. Number two, and by the way, it's been used in other areas and shown responses. Number two, the middle arm doesn't show that sasallimab is not active. What the middle arm shows, where the hazard ratio is above 1, is that if you give maintenance BCG, it's extremely important. And then the addition of sasallimab on top of that gives you the boost you need to reduce the risk of relapse. So I would turn it around the other way and say it's not that arm's not active, but in the arm where you give the maintenance therapy, you get a boost.
All right, last question to Matt.
So P1 blockade approved already for the treatment of BCG unresponsive non-muscle invasive bladder cancer in many parts of the world. How many patients on your control arm received immune checkpoint blockade at the time of becoming BCG unresponsive?
I don't know the detail of that. The numbers are will be really small. I mean, we all know, Josh, you've highlighted it, pembrolizumab in muscle-invasive bladder cancer, BCG refractory, is not as widely used as perhaps some people might have thought. There are ongoing trials, Keynote 676, we haven't seen the result of that. Those trials feel important to me, but as it currently stands, I don't think salvage immune checkpoint inhibition is necessarily the right answer to this question without randomized data showing it's active there. And it comes back to where I started, Brian, which is early immune checkpoint inhibition, strong rationale, 1,000-patient, big, positive randomized trial with all of the very fair caveats. There's no perfect trial, but this is as good as we're going to do in this setting with the survival signal, which I believe is premature and not harmful, Brian. I don't believe there were adverse events.
You don't think immune therapy is harmful, so
associated with that. I accept.
All right, we're going to go on to the question.
So
right?
just,
Matt's got one more.
I just wanted to clarify my point. So just to be clear, you're asking for approval in a population that's less enriched for bad outcomes when the treatment approach is not being widely used in patients who are more enriched for a bad outcome.
Yeah, and my pushback with that is one of the problems which my urology friends have is they tell me the data is not very robust with this single-arm trial with 120 patients. That's why we do big randomized phase 3 studies. We've done that. We've achieved our goal. We did what we were asked. It's time to move on.
All right, it is time to move on to the question. So if you could advance the slide, Tom, and I don't know, I have to pull up the Slido question. So everybody on the stage and who I've asked you in the audience to vote, you have to do the QR code to get the Slido up like we did last year for those of you who are here. So I'm just asking, if you were asked to vote, you're going to vote. If we didn't personally ask you to vote, please don't vote. So we just want a smaller group like it would be at ODAC. You can go ahead and vote. So basically, yes, I think the benefit risk does support it, and I would recommend approval. No, it obviously doesn't. You can abstain if you want, just because that's how they do it, but please don't abstain.
Ooh.
And then once everybody's voted, Josh, maybe I'll start with you. I want you, we only have about 5 minutes, so quickly you're going to say, I voted yes, and here's the one reason why. I voted no, and here's the main reason why. Something like that. Give it a second to, we have 21 votes. That seems like a lot. Okay. All right.
Why don't we ask the 11 people who voted to put their hands up? Because we have 21 people on ODAC. So, and they're going to have to say if they did it or not. So if you're one of those 11 people, if it's a yes, put your hand up. It should be approved.
Who voted yes on the panel?
On the panel.
3 yeses on the panel, 4, 5.
5. On who voted no on the panel? On the panel. 1, 2, 3, 4. And who
it looks
voted,
about 50-50.
And who
which
voted
is actually,
abstain?
We didn't. Oh, okay. You're not allowed to abstain. I just put it up there because that's how they do it. But so it's about 50-50. It looks like, yeah, we had more votes than we were supposed to have. That's okay. I'm going to start with Josh. How did you say I voted yes or no? And here's just one main reason why.
I voted yes. I do think this is a meaningful difference for our patients with early stage but high risk bladder cancer.
Sam.
I voted yes. To give an option for these patients, selection will be important, but having the option, I think, is probably more important.
Okay, Shilpa.
I voted no because I don't think that everybody would benefit from this, and if it were just for CIS positive patients, I would have voted yes.
We'd consider approval with a restricted label. Okay, Brad.
I voted no, just given the concern of harm to patients with 2 years of immunotherapy in this space.
I voted yes. The trial met its primary endpoint. I think the decision should then be between patients and their physicians.
You're influenced because you're so close to Tom. I think. All right, who in our other panel? Jonathan, did you want to?
I would have voted no. I think the long-term data are immature and are concerning.
Wow.
I voted no. I think for the benefit, the absolute number, we should take the 2-year, which is more, which has mature events, which is 5% difference versus 10% of real life changing events. And I think that risk benefit at this point, as it currently stands, is not enough for a type of events where it's not completely clear how important this is really for patients.
Petros.
Although I think the use of the drug is going to be minimal, I voted yes. Although, because I think all the points were made were good, but I voted yes because I think it's a phase 3 trial, properly designed, appropriately powered, met the primary endpoint, it's reasonable to give the options to the patients. At the end of the day, will be a minimal use, but should be available for patients.
Okay, why don't we just finish with Kala?
I voted no for the risk-benefit ratio, and the fact that, these are patients on trial, and we saw these toxicities. What happens to patients off trial when these drugs are being used randomly in the community without the support?
Okay. So, well, it's 50-50. ODAC's just advisory, so the FDA can do whatever it wants. You can have time. That's okay. All right, thank you, Tom. When I get asked what my favorite part of a meeting is, I think this is going to be it. Watching Tom get peppered with questions for a half hour is A+. All right, we're going to move on. If you go to the next slide to the POTOMAC data, Jonathan, who wasn't part of the trial, I believe, has kindly agreed to defend the data. You can be nicer to him than you were to Tom. If we just go to the next slide. So I'll start off again, giving the FDA. I'm going to steal your clicker. Just the clicker. Sorry. Thank you. That's right. So as with the CREST trial, so this is a large trial called POTOMAC. Same population of BCG naive, high risk, non-muscle invasive. Pretty much the same definition. It did have this multiple recurrent large type definition. This was durvalumab for 1 year, but otherwise similar trial. BCG induction and maintenance, or adding durvalumab, and again, that third arm that we're going to sort of put to the side in the interest of time. Primary endpoint, investigator assessed again, DFS as defined by persistence of high risk, non-muscle invasive disease, muscle presentation of NMIBC or metastatic disease, persistence of CIS at 6 months, or death. See a DFS hazard ratio of 0.68, significant at the 0.01 level. 3-year DFS difference of about, 4%. OS hazard ratio below 1, but with a wide confidence interval. And again, about a 5-fold increase of high-grade treatment-related adverse events, and 45% high-dose steroid use. All right, here are my problems with the data. So actually, the opposite of what we saw in the other trial, the DFS benefit is completely absent in the third of patients who had CIS in this trial, a not small subset with a hazard ratio of 1. There was no blinded independent review, right? We saw that be insignificant in the other trial. There was no blinded review here, so we don't know what reality is. Interestingly, you'd think if you add another immune agent, you should get some immune endpoints. Dave McDermott's in the audience, he'd be proud talking about immune endpoints, but we don't see any difference in the CR rate. We don't see any difference of the duration of response in that CIS population. So you're not getting the immune effect that you would hope for by adding an immune agent. Again, the EFS difference was largely, almost exclusively recurrence of high-grade disease. So this is not preventing progression to T2 or eliminating the need for cystectomy, et cetera. This is almost exclusively recurrence of T1 disease. Again, OS not different yet. Significant grade 3 immune-related adverse events and really significant steroid use, again, in an elderly, frail population. I didn't present the data, but the EORTC quality of life scores were worse in the durvalumab arm, often exceeding the 10-point arbitrary but accepted clinically significant threshold at certain time points. And so this voting question is the same. Does the benefit risk support the approval of durvalumab in this population? I'll turn it over to Jonathan, who will present on behalf of the sponsor.
No relationship to this trial whatsoever. So bear with me. So this is POTOMAC, a randomized open-label phase 3 study conducted globally, enrolling patients with high-risk non-muscle invasive bladder cancer, T1, high-grade or grade 3 disease, CIS, or those who had multiple or recurrent tumors. A 3-way randomization. We'll talk about the BCG induction and maintenance arms of the trial, the control arm, and then the addition of durvalumab. And in this trial, we saw a significant and a robust improvement in disease-free survival in patients on this trial with a hazard ratio of 0.68. Again, roughly a third reduction in the risk of disease recurrence or progression. Primarily, as Brian said, primarily reduction in recurrence events. We see the forest plot down below. I think it's misregistered a little bit. Not a tremendous benefit in certain subsets, but again, this is a large randomized trial. And within the large randomized trial, you have to take the entire trial. If you're looking at particular subsets, you may get, as we saw in one trial, for no consistent biological reason. One trial says one subset does better, another trial says another subset does better. I think we have to look at the totality of the data. PD-L1, again, not really very helpful here. We do see that there is a modest reduction in the risk of death, although without confidence intervals are wide. It's, I think, notable that it's less than 1 as opposed to more than 1 in terms of the hazard ratio. When we think about the context of the trial, even in the context of steroid use and other immune-related adverse events. It's also 1 year of therapy. The toxicity profile, we see that the risk of high-grade AEs is relatively low here in patients treated with durvalumab. There are the expected immune events, but the tornado plot, I think, looks quite favorable with relatively few high-grade events, except for increasing lipase, which we know is an insignificant event in nearly every patient who has that. But there is no doubt that steroid use was higher and that we need to be careful in this patient population as we give them these agents. The treatment was 1 year, which is a shorter course. I think it has the advantage of potentially reducing the likelihood of adverse events in the second year, and with only 1 year of therapy, the hazard ratio was 0.68. And so I think that's quite a balance in terms of the risk of toxicity, the exposure, the need for IV therapy only for 1 year, and actually reduces the risk of relapse fairly substantially. We do see a change in some changes along the way in quality of life, but none of them consistently are in favoring one arm or the other, and overall, it did not have a substantial effect on patient-reported quality of life. And we know this from seeing patients receiving these agents, that the quality of life overall is quite good, and that patients, it's the rare patients who have major severe effects on their quality of life.
So just go back one. All right, we're going to open up the presentation to discussion. Josh, you want to go first?
Could you show us the forest plots again? I guess, Dr. Rosenberg, my question is, if you look at the BCG strain, it seems to matter there. And so my question for you is, this was not done in the US. These were not US patients. You have a study, POTAMAC, which is not read out yet, to my knowledge, has it?
Not to my knowledge.
Yeah, so how do we know that we can give this in the US? Our patients are going to get TICE, which don't do as well. So are you going to be giving a different strain of BCG with this, and how will you manage that in the US? Because it seems like that's an important part to this. Because, again, most of the EFS is driven by the BCG, which, again, was not done in the US, which patients will be getting TICE here.
Again, I think the subgroup analyses you have to interpret very carefully, and I don't know that I would really focus on that. I think we are going to see other data coming out. You know, it is a fact of life that TICE has been relatively unavailable, and the choice was doing the trial or not doing the trial. And so the trial was done, and these are the results.
So without BCG, they shouldn't get it?
I think
without BCG, they should not get this treatment. This is not, the treatment is combined with induction and maintenance.
Thank you. Shilpa?
Yeah, so thank you for presenting the data. So I think the toxicities mentioned, the grade 3-4 was of 8%, so it was not that much. So
right.
And 1 year of the immunotherapy used makes sense. So what is your take on that none of the subgroups showed benefit, like the CIS? Why was there not much benefit seen in that group?
I think random things happen in randomized trials, to quote Rob Dreiser, and sometimes subgroups don't show benefits. That doesn't necessarily mean that there isn't a benefit there. It's just in this study that those patients did not look better. You could argue whether, you know, did you look hard enough for CIS in the trial, and maybe you did or didn't find it. I think this is, but the data should be taken in totality.
Fair enough. Brad, did you?
Yeah, I would just have a comment. So, I mean, we have 2 years longer follow-up on this trial than we do have on CREST. And I guess with that follow-up, have you had data on cystectomy-free survival? It seems like we'd have some of that available at this point in time.
Not that I know that's been reported. I don't know, actually.
Yeah, I don't think it was in the paper. Matt?
So we've heard that the biomarker doesn't perform well in this context in a couple of studies, but actually in each study, the effect size is larger in patients with higher expression of the biomarker. And so in the context of a patient population that otherwise does pretty well, why should we not look for a biomarker for enrichment?
Well, I think the study wasn't designed specifically to look at the biomarker. I think it's an interesting question. But I think we need more data on it in this context. It's not, if a physician chooses to obtain a commercially available biomarker and makes a decision based on it, that's their business. But the study wasn't designed to answer that question.
Which country, did US enroll any patients on this study?
I believe it was, they did, but I don't know how many.
You don't think so, Josh?
No,
I don't remember.
It was all Europe.
It was all Europe.
All outside.
All ex-US.
Yeah.
Sam.
Dr. Rosenberg, looking at other intravesical salvage therapies for BCG unresponsive disease, the impact of complete response is essential to have any type of long-term response. So how can you explain, at least pathophysiologically or immunologically or any logically, how we get the differences in the response rates when there's no difference in CR and no difference in duration of response?
I think the differences are, so remember that this is not just a CIS trial, right? There were papillary tumors. It was an adjuvant study for the majority of patients on the trial. Okay. And in those patients, it prevented recurrence, but there's no duration of response and there's no response rate because those patients were all in CR at baseline after resection.
In understanding that, though, if you had an impact in terms of disease at a certain time point and resection of that disease, that could have been low-grade disease, and still those patients could have recurred. We don't know. We only know high-grade disease, correct?
Correct.
Okay. And then lastly, and you may not know the answer to that, we don't know in terms of cystectomy-free differences. There was an implication made by the FDA that there was really no difference in progression to muscle-invasive disease. Do you know if there was a difference or not?
I don't know if there's a difference or not, no.
Brian, quick question.
Sure.
Great filling in the job, Jonathan, I would say. Question about quality of life. Since we talk about benefit and risks here, quality of life is very important. Can you comment on how appropriate this quality of life PRO metric is for this patient population in this disease setting? Yeah,
I think it's as a general rule, these weren't necessarily designed for immunotherapy patients. And so, I think they're very general questions that are being asked of patients. And so they don't necessarily specifically address the issues for this patient population, but on the other hand, they're widely used and well validated.
Anybody else in the panel with a question? If not, I can see if anybody lower panel has a question. Petra, another one? Sure, go for it. Oh, sorry. You go ahead and then Brad.
Again, great job, Jonathan. The other question is back to what Matt asked before. If we have a checkpoint inhibition approved in the BCG unresponsive setting with probably lower than expected use, the question, now we have more intravesical therapies available since the conduction of that trial, nadofaragene firadenovec, Anktiva, and now TAR-200. In the context of those salvage therapies that may impact cystectomy-free survival, to Brad's point, do you still see value in meeting the primary endpoint of this trial?
I do, and I invite those people who make those drugs to do the frontline trial in combination with durvalumab and a checkpoint inhibitor and BCG. I think, or in comparison to a checkpoint inhibitor and BCG. We don't save our best for last. We usually try to put our best foot forward when we treat for cancer, and I think this attempts to do that. And I think we really need to start looking at comparative trials, and I think this is one of the ones that really has shown that there's a benefit in the combination of treatments. And so, single-arm, small trials that lead to drug approvals, I think we really have no idea how active they really are.
Okay, we're going to do last question to Brad, and then we'll do the
vote.
I
just want to make one quick comment on the CIS. The CIS population in this trial is very different from the CIS population in CREST, as there's much more concomitant high-grade T1 and TA. It was much more pure CIS in the CREST trial. But the same question we asked before, what about those life-altering toxicities, type 1 diabetes, myocarditis, things that will impact a patient's life expectancy independent of this disease.
You know, if they really were impacting the patient's life expectancy, the hazard ratio would be above 1. It's not.
John, I think you might have bought yourself a ticket to ODAC. I mean, thank me later. All right, we're going to go to the vote. If you want to switch up the slide. You don't want to do the vote. Late breaking. Okay, we're not going to do the vote. We're not. You probably heard that. So we're just going to go around to the panel, and then maybe Mikhail, Petros, Tom, if you want to chime in, and Kala. We'll just ask how you voted. Somebody keep track. I don't have a pen. Josh, we'll start with you again.
Yeah, again, I would vote for approval. I do think there's a benefit for our patients, and I like to give our providers an option for better therapy.
Sam?
Yes, approve, give an option, 1-year therapy vis-a-vis CREST, which I already voted yes for, and clearly the similarity of the hazard ratios between there's got to be a signal, and which is better, obviously we don't know, but I vote yes.
There you go. Shilpa?
I vote yes because of 1 year of therapy, less toxicity compared to the CREST trial. And I think it's good to have some option for our patients, but 1 year is reasonable.
You flipped a vote here, Jonathan. Keep that in mind, Chief.
Okay, Brad?
Yeah, actually, I voted yes for this for the simple reason that we have much longer follow-up on this trial. So I think with that extended follow-up, I feel more comfortable in the rates of those like life-threatening toxicities were much less.
Matt?
Yeah, I voted yes. Same exact effect size as the other study for which I voted yes.
Thank you for being consistent. Mikhail, give a mic.
Yeah, I'll be consistent here. I vote no because of the benefit-risk ratio. We have a 4% absolute improvement versus 10% life-changing adverse events.
We need you for the odd number. Tom?
So I'm not going to vote.
Abstain, okay.
Abstain. I'm going to abstain because it would be ridiculous for me to vote against it, having made my little speech for POTOMAC previously. So
They're not in competition, are they? They really aren't.
I think it's a difficult decision.
That's why it's at the UDAC. Petros, give him the mic.
I will vote yes for this as well for similar reasons. A properly designed, properly powered phase 3 trial met the primary endpoint. It's good to have the option for the patients. Again, the uptake will be interesting to see. Maybe low, but it's good to have the option. So I would agree, and I would vote yes for that reason.
Paula, last word to you. And then we're actually going to show one more slide after this.
So you flipped my vote too, so I'll vote yes because it's a year of treatment, longer follow-up, and the fact that it's an IV treatment that might involve a medical oncologist and that expertise might make it a little bit safer.
All right, we have 7 yeses, 1 no, 1 abstain. Jonathan, if you just go forward. Tom made us keep going. There should be a summary slide. I think there might be going backward. One more. Yeah. So Tom made this summary slide of CREST, POTOMAC, and also Alban, which was a negative trial presented at ESMO. Brad, you did an excellent discussion at ESMO. Anything you want to say, just sort of briefly, sort of summarizing, maybe bringing in Alban and how, maybe basically a summary of your discussion.
Yeah, I mean, I think
sorry to put you on the spot. I didn't tell you what I was doing. I just got a note for it. I just got a note.
3 trials. I mean, Alban was negative. I think it's probably not a drug effect. It seems like there was it had a different endpoint. It looked at any recurrence, not just high-risk recurrence, which was one of the differences, and multiple factors at play. I think as we look at both POTOMAC and CREST, very similar effect size, but with half the amount of systemic therapy in POTOMAC than CREST and a much longer follow-up, with I think a slightly more favorable toxicity profile, though CREST trial comparisons overall. I think I try to make a lot of sense of that CIS story. Like, why is the CIS hazard ratio worse in POTOMAC and better in both Alban and CREST? And as I looked into it, I think there was a clear difference in the CIS patients. Like, CREST actually had the higher propensity of CIS, but it was mostly pure CIS if you looked at the analysis, whereas POTOMAC, there's a lot more concurrent disease. And so I think at that point, it's a very heterogeneous population. And I think I think that story makes it hard for you to say, oh, we should do it only in CIS or not, because of that overall. But I think at the end of the day, there is a 5% improvement in EFS with a 5 to 7% risk of life-altering toxicities.
Okay. And Josh, I'm told you also helped make the slide. I have a note to that effect, so credit to you. Anything you want to say? You wrote an editorial in Annals of Oncology about what Alban was the study published there. Yeah. Anything you want to add?
No, I think that helps trying to think about why these are different. The key thing, though, I think, is if we're going to look at CIS, it's set for the trials to actually do biopsies. And I think that's why CREST showed a difference, right? Because those patients actually had a biopsy to look at CIS. I mean, the overall event rate was higher. The difference was greater because you looked through biopsies. So if we're going to look at CIS as an endpoint, you need to do biopsies because you can't trust the surgeon's eye. You know, you need the pathology.
Okay.
I think we should congratulate the sponsors for doing randomized trials in non-muscle invasive bladder cancer. This is hard to do of all the trials, and I think it's a real positive for the field.
All right. Great job, everyone. Great presentations. Appreciate it. I thought that was pretty fun. Was that pretty fun? All right. We have one more part before we break for the day. Okay. I'll excuse the panel. We need a couple minutes of changeover. We're going to do the first part of our Uromigos Cup trial contest. I think Colin and Mikhail are each going to present a bladder cancer concept on behalf of their team, and then at the end, everyone can vote. And most votes gets how many points, Tom? Doesn't seem like a lot. How about 5? 5 points. You could tell this is very official. So whoever gets the most just straight up vote will get 5. So give us a couple minutes and we'll do a changeover.